Muhammad, I'm there. Thank you. How are you? Alaikum
The
salam.
floor is with you. You can use 2 minutes better than two, so you can start as you wish.
Yeah, okay, I will. Thank you, everybody, for being here today. Thank you, Dr. Muhammad, for the invitation. Thank you, all speakers. Hope to have a good time and fruitful discussions. I am trying to share a couple of slides now. Just give me a second. Okay. So we are continuing today what we started yesterday on expecting the unexpected in the world of ophthalmic plastic surgery. And as I started yesterday and commented that common things are common, we shouldn't forget this dictum. Never forget that common things are common. We are going to mention a couple of uncommon cases, but this does not mean to forget that common things are common. The English proverb that we were taught as medical students says, when you hear hoofbeats, think horses, not zebras. Horses are everywhere, zebras are only in Africa. Rare things are rare, but they exist, like a white peacock, like the Stonehenge, like a purple carrot, albino crocodiles, white tigers, red bananas, rain from an airplane, red corn, volcanoes. All these are very rare occurrences, but they exist. So I am now inviting the first speaker, Dr. Muhammad Moin. Would you share your screen, please?
Yes, I'll just share my screen. Assalamu alaikum. I can't, it's not starting my video, but anyway, you cannot start your video, but I'll share my screen. It is not letting, okay, now I can start my video.
Sharif, can you please stop share? Stop share first so he can share.
I think I did. Am I still sharing? I
Yeah, now it's, yeah.
Yeah, please.
Let's see. Let's see where it goes. So today I'm going to discuss an interesting case of, let's say, start screen. And so can everybody see my screen?
Yes.
Yes, thank you.
Clear now.
Thank you very much, Dr. Muhammad Al-Amri, for organizing this MEOM conference. I think it's a wonderful opportunity for the people from this region to participate in this meeting. And thank you, Dr. Sharif, for introducing me. And my talk is going to be on one of the unexpected presentations. And I'm just going to show you a case with a 5-year-old girl who presented in 2020. She had a left upper lid huge swelling since birth, and she had a complete mechanical ptosis, which was obscuring her vision. Just this, okay. And on crying, it was increasing in size. Swelling was reddish in color, which blanches on applying pressure. So as you can see, this was her picture. We just got a photograph because this I actually did in the hospital at that time. We didn't keep a picture at that time. So you can see the upper lid is all completely ptotic. It is closed, and there's a large reddish mass. So the differential at that time was either it's a capillary hemangioma, or it's a cavernous hemangioma, or it's an AVM. So the most important diagnosis or the treatment strategies were different at that time. So I'll discuss because she had been referred to us and she'd had multiple treatments before. On examination, the visual acuity did sort of improve to 624 at that time, and she was having stimulus. I'm not sure at that time if it actually was improving or not, but our residents did mention that there was some sort of vision, but probably that could be doubtful. But there was no proptosis. It's all a lid lesion, and no ciliary or conjunctival congestion was seen, and the cornea and the posterior segment are all normal. And the mobility was immobile. The lesion, it was inseparable from the skin. It was painless. Transillumination was negative. There was, we couldn't differentiate a bruit, which is typically seen in an AVM. The Valsalva maneuver increased in size, and pulsations were present as you would expect in an AVM. And duration was 5 years, and the size was 30-30, and it was soft and reddish in color. She had previously received 3 intralesional triamcinolone injections because it was confused as a case of capillary hemangioma, but there was no improvement noticed. So in our hospital, we had the facility of having a carotid angiogram, so we are able to differentiate more easily over here. At that time, our initial diagnosis was, or differential was, an AVM, because the pulsations were positive. It could be a venous malformation, could be a lymphatic malformations, a capillary hemangioma, a cavernous hemangioma, a neurofibroma, or a carotid cavernous fistula. But our main working diagnosis was an RAVM at that time. The patient had CT scan and orbit with IV contrast, MRI brain with orbit contrast, and digital subtraction angiography as well. So here you can see this is a typical CT scan of that girl who was seen over there. And you can see the lesion is present in front of the eyelid, and it's enhancing on the scan. And it is pretty intense. You can see it's going pretty much forward over here in this area. And this is the carotid angiogram, which we saw in this patient, and you can see the ophthalmic artery, and this is the area where the AVM was. This is a branch in the upper lid where the AVM was seen. And initially, the diagnosis was the same, and the question was what to do at that time, because we were not dealing with AVMs very routinely. We were doing carotid cavernous fistulas, but we had some orbital lesion, but this was our first case doing a preoperative tumor embolization with the help of our neuroradiologist. So we used an expansile PVA particles. The other options were to use a gelatin sponge, microsphere, there's onyx, and there's squid or histoacryl glue, but they all depend on how long you want to occlude the arteries or the AVM for before you go ahead with the surgery. At that time, we did a occlusion, and then per-op bleeding was encountered. There was no transfusion required. And 1 year later, in 2021, after the first excision, amblyopia therapy, and the vision improved from 624 to 66 at that time. And this is something which is a post-op patient surgery. We didn't have per-op pictures because at that time we were not keeping a record of her, or they were misplaced at that some time. But this is what we saw after 1 year. So you can see the AVM has drastically been removed. You can see the scar over here. It was a pretty messy operation initially when it was obviously embolized, but still there was sort of oozing up from that area. But this is how it had healed over time. And then when we came back, this is initially, and this is 1 year later when she came over there. But still, she needed more improvement for cosmetic reasons because it was still there. And you can see we did an angiogram again, and it still showed a presence of the AVM partially there as well, but it was markedly reduced in size. So we went for re-embolization with PVA particles. Just to show you what PVA particles are, they are polyvinyl alcohol particles. These are small particles. They come in different sizes. You can see from 50 microns to 1,000 microns. So we utilize about 200 microns particles to embolize that area. And this is typically you go through a femoral artery and you go into the ophthalmic artery. You avoid the central retinal artery, and then you go and then you release these particles, and that embolizes that area. And then you keep the patient on surgery list in a couple of days' time according to your schedule. And then we went on. So the most challenging thing was to decide what we're going to do at that time. So we planned to go ahead with the surgery, and we excised the tumor. You can see the tumor was there, and we did as much of resection as it could. It was the skin. What was difficult in that the skin was totally adherent to this lesion, and we could not separate it from the lesion. And we didn't know. Initially, I had thought we'd just go in, that the lesion would be there, and we'd just remove it, and that would be the end of surgery. But we ended up sort of losing all the skin over the lesion. So here you can see, and there was pretty excessive area of skin loss, and the lesion was actually going very near to the lashes. So we had carefully decided to sort of remove that area of the skin, but still there was some medial area, but we just wanted to do this area which was affecting her visual axis at that time, because we thought initially that this would produce quite a bit of scarring. Then we sort of took the map for our skin graft and took it from a sort of the inner side of the arm. And this was the graft we took in. And then we put a full thickness graft on her upper lid. And this is how she looked 2 months after surgery. And this is 2 months still after surgery. And this is today after surgery. I think it's 6 months or 7 months down the line. And we sort of telephoned her and got her pictures today as well. So you can see, over the time, we were able to successfully get that huge lesion out, and it had to be done in 2 steps. But getting the second step, where we needed to skin graft, really worked very effectively. Our threatened post-op complications were graft rejection, infection, or a hematoma, or even a cicatricial ectropion, but thankfully we did not encounter that over time. So in the discussion at the end, I would just say the contour PVA particles are small and irregular flakes of polyvinyl alcohol, which are used for permanent occlusion within a blood vessels. The contour particles have been proven to be safe and effective in many clinical scenarios for decades. So it's very important to liaison with your neuroradiologist, and you can do this lesion pretty well. If you have time, I'll just share this my screen. This, because we did not get the video of how the embolization was done. I'll just take liberty to show it from YouTube. There's just a 1 minute video. It's very interesting just to see as ophthalmologists. This is by Dr. Sandeep. He's shown this. So they had a similar ophthalmic artery feeding AVM, and you can see the AVM is over there. So similarly, we have in our department, we have neuroradiologists over there, and they go in and they would catheterize the femoral artery, and then they would go through the femoral artery. And then here you can see there, actually we're used to an ophthalmologist, where is the actual field where the surgery is done, but you can actually see it is being done somewhere else. And they're just seeing on the X-ray screens over there where the thing is happening inside the orbit. This is selective left ophthalmic artery injection. So you can see the injection is going over there, and here you can see the Onyx injections they use, and this is sort of closing that lesion over there, and then they'll do a post-contrast enhanced image, and you will see the main area of the lesion becomes absent over there. So this is the technique through which they would do a post-embolization video, and you can actually see what is happening. So I think, thank you very much for watching, and if there are any questions, I'll love to take those.
Well, we have the time for questions by the end of the session. So thank you very much, Dr. Mohammed, for the nice presentation and the good job you've done. And now I invite Dr. Thabit Odat to speak, please.
Thank you, Dr. Sharif Awan, for the invitation, and thank you, Dr. Mohammed Lamri, for the invitation also. Assalamu alaikum wa rahmatullahi wa barakatuh. My case today, actually, it's about, just wait a minute. It's about blepharitis caused by silicone oil after penetrating ocular injury. So this patient was a 20-year-old male patient, was referred to the oculoplastic clinic complaining of left upper eyelid swelling, as you see here, over the last 6 months before the presentation. This presentation came to me to the clinic in 2006. So the swelling was gradual in onset. It was red, paleless, involving the upper eyelid, and causing severe ptosis. So the past medical history and past medical and surgical history revealed perforating eye injury caused by hammering metal on metal 12 years before presentation. It was 1994. Primary repair of the corneal wound was done, followed by cataract extraction and posterior scleral wound repair, in addition to 3-port pars plana vitrectomy with intraocular silicone oil injection. The patient was lost to follow-up for 12 years. So during that time, there was a metallic foreign body, as you see here, in the CT scan, located behind the eyeball and adjacent to a vital intraorbital structures, and therefore it was left in place as it was not interfering with vision, and no signs of orbital cellulitis were noticed at that time. So they prefer to keep the intraorbital foreign body in place. In examination, there was, as you see, there is a severe ptosis, there is swelling, there is redness, and it was not hot to palpation. There was mobile subcutaneous small lumps that were not tethered to the skin or to the underlying tissue. And so we did a CT scan for the patients. As you see here, the orbit shows hyperdense, homogeneous over-opacity that occupied the anterior half of the left vitreous cavity, which was silicone oil, which was left there for 12 years. And also you can see discrete, small, hyperdense, homogeneous small opacities behind the globe, and also above the eye and in front of the foreign body. And there is also mild thickening of the upper eyelid in the left side. So also the foreign body was still there in place. It was adjacent to the greater wing of the sphenoid, just medial to the lateral rectus muscle, at the middle of the lateral rectus muscle. We did surgical expression transcutaneously, and we found that there was pre-apoptotic fat was found to be invaded by silicone oil globules. As you see here, these globules were semi-solid. It was not soft. As you know, the silicone oil is usually it's a liquid. It's not semi-solid or solid, but in this case, it was semi-solid. The levator aponeurosis was dehisced also. So we excised these granules and sent to the histopathology, and it shows cyst of silicone oil associated with lipogranulomatous inflammatory action. So this is the patient after 1 week. So you can see still he is having ptosis. It's not fully corrected because of the swelling. In this case, the patient had a history of perforating eye injury by a high velocity object, for which primary and secondary repair with the 3-port pars plana vitrectomy and silicone oil injection were done. So we think silicone oil may have leaked through the pars plana vitrectomy ports and posterior scleral wound at the foreign body exit during or after surgery. Our patient was lost to the follow-up for 12 years. During that period, intraocular silicone oil emulsification might have occurred that led to an intraocular pressure increase that aggravated the silicone oil leakage outside the eye. The migration of the silicone oil from the subtenon space across the levator complex into the pre-aponeurotic fat might be due to a plane opened by the foreign body at the time of trauma, or it could be intraoperative trauma. So the essence of the levator aponeurosis, which was seen intraoperatively, could be due to the weight of the silicone oil and to the lymphedema caused by the inflammatory action to the silicone oil foreign body, which is called siliconoma. So it could be due to weight, could be due to the trauma, it could be to anything. In 2012, Schoenfeld and Agmon-Levin described a syndrome which is called autoimmune inflammatory syndrome induced by adjuvant, which is an antigen-specific immune response where silicone would act like an adjuvant in the genetically predisposed patients. So it as just an adjuvant to the inflammation. It's not the inciting agent. So acute adverse effects such as treatment site reaction, such as pain, swelling, edema, infection, necrosis, and migration of the injected material could cause acute pneumonitis or even organ failure, are common adverse effects of liquid silicone effect and have been well described, but late onset autoimmune inflammatory adverse effects are starting to be increasingly reported. Granulomatous reaction is the most commonly described immunologic and histologic findings associated with late onset inflammatory reactions secondary to silicone oil injections. Most of these granulomas form within the first 12 months after injection. In our case, the first syndrome was described in 2012, but our case was 2006, which is about 5 years before that. But the first case of injecting silicone in the body was for breast augmentation. It was in the early 1940s. So there has been a lot of complications for this procedures, but it was not mentioned to have such complications in the literature. So AGA also could be caused dermal filler due to dermal filler as in this patient. She used to inject herself with filler. So it causes also the AGA, which is the autoimmune inflammation syndrome. Take-home message from this patient that silicone oil ptosis occurred when silicone oil was left in situ for an extended period of time. So it's recommended to remove intraocular silicone oil after 3 months to prevent complications. Long-term follow-up is needed also for those patients who have to retain silicone oil for extended period of time. Mechanical ptosis can be caused by migration of silicone oil after PVV, especially if the tenuous capsule is breached either by trauma or iatrogenic during the surgery. Long-standing mechanical ptosis can lead to dehiscence or even insertion of the aponeurosis. And remember that delayed autoimmune inflammatory syndrome induced by adjuvants is a newly described syndrome that needs further investigations. Thank you very much.
Thank you very much, Dr. Abid. That's very interesting, actually, and nicely presented. Now I invite Dr. Tamer Gaudat. Are you ready, Tamer? Dr. Tamer? Hello, Dr. Tamer, are you there? He was here a few moments ago. Dr. Tamer Gaudat. Yes, Tamer, please. Unmute yourself, please.
Hello.
Yes, we can hear you now. Okay.
I will share my presentation. Bismillah ar-Rahman ar-Rahim. First of all, I'd like to thank you, Dr. Sharif, for the invitation, Dr. Muhammad Al-Amri, and it's a pleasure to be with you all. Today, I will talk about something unexpected during evacuation of an orbital abscess. حضرتك سامعني كده دكتور شريف؟
Very well.
طب الحمد لله. Okay, let's go. طيب ده 5 years old child, he came complaining of severe pain.
Your screen is not shared. Your screen is not shared yet.
Not shared. ايوه. اوكي كده؟
Yeah, okay, كده تمام. Go ahead.
Okay. تمام. هو 5 years old boy complaining of severe pain, recurrent orbital swelling, droopy eyelid, as you can see. There was no clear history in this child. His parents told us that he had minimal trauma. He fell from a few steps, and there was no wound, and he developed this swelling, and every now and then he took antibiotic, and he became better, then recurs, and so on. So of course, when we have such thing, we have to make our differential diagnosis. Is it orbital infection or inflammation, or is it a mass? So first of all, we have to do the basic radiology. For example, the ultrasonography first. There was a swelling, as we can see here, like a cystic swelling behind the globe, could be like this. And in this patient, we did the CT, and we had this swelling pushing the eye downwards. As you can see here, it's a subperiosteal swelling, pushing the eye downwards. So I decided here to explore and open this swelling or cyst. This is the places where we can see the pre-septal cellulitis, post-septal cellulitis, or orbital abscess. So here we took the decision to make surgery because he tried many antibiotics and it didn't work. So I opened the skin. They came late, and as you can see, the cornea was opacified because they were not convinced to do the surgery as early as possible. And once I opened this crease incision and started to approach the cyst and open the abscess, foreign bodies started to appear one after another, till I got out more than 10 foreign bodies, wooden foreign bodies from the cyst. And it was a very big surprise to find all these wooden foreign bodies. So what I missed during the examination, and this is very important to thoroughly examine the patient for any small wounds. Here, as you can see, above the crease, there was a very, very small scratch. This scratch, it seems that this was the wound when he fell down and a wooden foreign body entered the orbit. And because it was a very clean-cut wound, it healed within few days. And they started to present when there was orbital infection and orbital abscess. So we have to examine the patient thoroughly for any superficial wounds, especially in cases of trauma. Also, what I missed during examination of the CT, this shadow here, when I went back to the radiologist and I spoke with him, he told me that this could be, of course, a foreign body inside the orbit. And this actually also in the coronal scans, these small shadows within the cyst could be a foreign body. So we have to suspect foreign bodies inside the orbit in case of trauma, especially if there is recurrent infection. So whenever there is an abscess, we have to search for any foreign body, even if the patient or the parents says that there is no trauma with any sharp object or anything like this. This is, of course, another case also with orbital abscess. And here you can see during evacuation of the abscess here, a lot of pus coming out. But in this case, there was no foreign body, and this was orbital infection from severe sinusitis in this child. So not every case, of course, there is a foreign body, but we have to put it in mind that sometimes there is foreign bodies inside the orbital infection or orbital abscess. Okay, thank you so much.
Thank you very much, dear Tamer. Nice presentation and a wonderful surprise. Thank you very much. Now,
Welcome.
I invite Dr. Tariq Al-Duais. Please go ahead, sir. I think you're muted, Dr. Tariq. Please unmute yourself.
Okay, thank you for all. My presentation is clear. Yes.
Yes. Yeah.
Yes.
Your PowerPoint is on now. We can see it and we can hear you well.
Okay, I will talk about several cases, lymphangioma for the same treatment. Case number 1, 8 years old, visit to our clinic with upper eyelid swelling in the right eye, 6 months. was not associated with diminution of vision, no diplopia, redness, discharge. There was no history of trauma. In ocular examination, there was a superior medial orbital ill-defined mass. There was no tenderness, pulsation, thrill, and periorbital change, and no
Sir,
change in size.
sorry to interrupt. You are not presenting the slide. Please present the slide. I mean, press presentation, because you are not. The slides are not turning. We are seeing the whole presentation. Yeah, now. Yeah, you can, present. So
Stop
as to
sharing.
enlarge the slides. No, don't stop sharing. Don't stop sharing.
Start with. Is it full screen or not?
Full screen, yeah. Please, full screen.
Now is full screen good?
Okay, it's okay. You can go, but you have to turn. You have to turn the slides so as to be synchronized with your speech.
Okay. In ocular examination, there is superior medial orbital ill-defined mass. There was no tenderness, pulsation, thrill, and periorbital change, and no change in size with change in position of false vulva. CT scan was done and show 5.2 millimeter ill-defined.
Let's change the slide, please.
What's the problem?
We don't see the CT scan. It's the slide number 4. We see slide number 3 now still.
Now CT scan or not? In my screen?
No.
What's the problem?
Now you click the next slide.
Your slide is clear or not?
We still see the slide of the patient.
Yes. Now?
Yes, if you click the, yes. Now we can see the CT.
Okay, full screen or not?
No, it's not full screen.
So you need to go on presentation mode. Yeah.
Now?
Yeah, this is the one. Right. Yeah, okay. Now by clicking, the slide will change automatically. Okay.
Okay. CT scan was done and show 5.2 millimeter ill-defined macrocystic mass, thus diagnosed as orbital lymphangioma, and advised the patient for observation. 6 months later, the patient complained of sudden onset of proptosis, progressive for 3 days, redness, pain, swelling of the eyelid, decreased vision. In ocular examination, visual acuity 616, OD 66OS. Globe in the right was axial proptosis, no pulsation, thrill and periorbital change, and no change in size with change in position or valsalva. CT scan was done to infiltrative and diffuse mass in the intraconal and extraconal space of the right orbit, and diagnosed as lymphangioma, and prepare the patient for aspiration under general anesthesia. Aspiration was done under general anesthesia. 20 cc blood was aspirated, and bleomycin 1 unit per millimeter saline was injected into the cyst wall in multiple punctures. 1 month later, follow-up of the patient, symptoms and signs were completely resolved. CT image results show no residual macrocyst, lymphangioma, and there was no signs of free bleeding. There were also no signs of recurrence at 6 months of follow-up. This is patient pre and post sclerotherapy. Case number 2, the same diagnosis, 2 weeks old with severe proptosis OS and severe exposure keratopathy and limitation of all ocular motility. MRI sequence demonstrate left axial proptosis, multilobulated orbital cystic mass of intra and extra conal space with multiple fluid levels. The post-contrast sequence will reveal heterogeneous enhancement, mainly enhancement of the margin of the cystic space. The same maneuvers, aspiration was done. 15 cc blood was aspirated and bleomycin was injected into the cystic wall in multiple punctures. This is the patient pre-op and this patient 1 month later. Case number 3, the same diagnosis, 12 years old with severe proptosis, chemosis, limitation of all ocular motility, CT scan, solid, well-defined, lobulated margin, and relatively hyperdense mass lesion without up 30 to 15 millimeters and height up to 20 millimeters in the left orbital cavity and interposed with medial rectus and inferior rectus. Aspiration was done under general anesthesia, and bleomycin for sclerotherapy is injected in multiple punctures. This is the same patient pre-op and 1 week's post-sclerotherapy injections. Last case, also 2-month-old with severe proptosis, severe exposure keratopathy with limitation of ocular motility, MRI 22 for 23 for 15 millimeters will define demonstrated mass lesion at right superior extracorneal intraorbital region. Lesion appear hyperintense in flare, hypointense to isointense to extraocular muscles on T2. Lesion causing significant proptosis and compression of optic nerve. Aspiration was done with sclerotherapy 1 day post-operative. That's the same patient at 1 month pre and post sclerotherapy. This is all Sana'a. Orbital lymphatic malformation, previously known lymphangioma. Those malformations are hemodynamically isolated vascular hamartoma that derive from venous system, embryologically have differentiated in a part or whole lymphatic vessels. They are present at birth and are composed of abnormal dilatation of lymphatic tissue that result from defective embryogenic development of predominant lymphatic channels. These cyst lesions are characterized by abnormal endothelial lymphatic cysts, which vary in size from few millimeters to several centimeters. It represents 1 to 2/4 of all orbital masses. It's 2 types or 3 types, microcyst and macrocyst, and mixed of them. Clinical features, clinically orbital lymphangioma can be asymptomatic. However, symptoms can appear slowly as mass involved the orbit or suddenly hemorrhage of the lesion, painful proptosis, compressive optic neuropathy, exposure keratopathy, restrictive ocular motility. Those symptoms might appear after upper respiratory tract infection or minor trauma. Diagnosis, CT scan or MRI might demonstrate either a cyst with an enhancement or solid lesion with cystic component. Management, conservative management include observations, simple aspiration of the anterior cystic component. Indication for intervention are acute orbital hemorrhage, progressive significant cosmetic disfigurement. Surgery can be challenging because encapsulated natures of the lymphangioma, which intervenes and interdigitate with surrounding normal vital structure in the orbit. Incomplete resection might result in recurrence. The risk of bleeding also increases with venous component. Multiple treatment modalities, radiotherapy, intralesional or oral steroid, intralesional sclerotherapy. Intralesional sclerosing therapy is used to induce cystic collapse by destroying epithelial lining. Option for sclerosing, absolute alcohol, sodium tetraacetyl sulfate, sodium morphoate, bleomycin, and doxycycline. Bleomycin is chemo agent that commercially available.
You have 1 minute. You have 1 minute more. I'm sorry. You have 1 minute more, sir.
Okay, we'll finish. While contains 15 international unit. A side effect of bleomycin, immediate side effect of intralesional bleomycin
Thank you very much, Dr. Tariq. Actually, you are the hero, not the patients. This is my viewpoint. You managed complicated cases in a very beautiful way. Thank you very much. Please stop sharing. Thank you. Now it's my turn. I am going to start sharing my cases. As I presented yesterday, 3 cases. This is the 4th case. This is an 18-year-old chap who had a lump above the left eyebrow with very irrelevant history. On examination, it looked like a small abscess. We thought of probably a granuloma, but otherwise the area was normal, and this is what we had: a small mass below the right eyebrow. Below the right eyebrow, and on palpation it was cystic. But once I opened it, I discovered the tip of a color pencil, a case very similar to that presented by Dr. Tamer. The history given by the patient never mentioned any accidents involving any pencils. So this is a case of an eyelid foreign body. My second case is a 45-year-old lady who came complaining of epiphora with history of intubation, lacrimal intubation. On examination, she had an upper granuloma at the site of the upper punctum with a lower slit-like punctum. I did punctoplasty. Of course, I removed the granuloma. I did punctoplasty and canalicoplasty above and below. And this is the idea of cheese wiring. Cheese wiring here, I am trying to address the young ophthalmologists here who probably represent a portion of our audience. Cheese can be cut by this small machine with the wire, and this is a video that shows the concept of wiring and cutting. This is how the tube can cut through the canaliculus and lead to this slit that we saw. So cheese wiring of the canaliculi is a postoperative complication of bicanalicular intubation. And the tube cuts through the soft tissue close to the puncta or canaliculi. And the possible mechanisms are either excessive loop tightening while finishing intubation, prolonged placement of the tube in place, inadvertent traction to the nasal end while extracting the tube, eyelid closure squeezing the tube loop medially, and or chronic irritation from the tube itself. But little is known in the literature about the effect of this cheese wiring on drainage. So second case is canalicular cheese wiring. My third case here is a 43-year-old chap who complained of red refractory discharge from one with eyes with irrelevant history. On examination, the punctum was swollen, red, and turned outwards with tenderness over the medial lid margin, pericanalicular inflammation with conjunctivitis, and on pressure at the canaliculus, we had the expression of these small yellowish hard nodules, multiple, known as sulfur granules. So this is a case of canaliculitis. On pressing on the canaliculus, you can have these small bodies that are sometimes are taking the shape of the canaliculus. This usually occurs above the age of 40. The risk factors for developing canaliculitis are obstruction due to probable trauma, or a foreign body like a punctum plug that has been retained there but not seen, or a diverticulum in the canaliculus. But most cases, we don't have an identifiable risk factor. The commonest organism to cause this condition is Actinomyces israeli, which is an anaerobic bacterium, gram-negative in nature, gram-positive, in nature, filamentous, and it is the most common, as I said, plus some fungi like Candida albicans, Nocardia, Steroides, Aspergillus, and sometimes maybe herpes simplex virus. Sulfur granules are like stones called dacrylith. Differential diagnosis includes chronic conjunctivitis, dacryocystitis, migrated punctal plug, and rarely carcinoma or canaliculus. The management includes the laying open of the canaliculus for complete drainage in a slit-like. It can be done under local anesthetic in the office with expression of all the contents. Otherwise, it will never respond to any antibiotic treatment. So this is a case of canaliculitis. My last case is a 23-year-old girl who came with upper eyelid masses, referred to me as chalasia for surgery, which is a very common mistake. On examination, I noticed sternal symmetrical firm masses in the upper lateral fornices, which were not tender, readily reducible, with quiet eyes and no other masses. And here are the masses. I think you all now know what I mean. This is a prolapsed lacrimal gland bilateral. The etiology of this condition is either ligament dehiscence, trauma, sometimes due to simple aging, and the diagnosis is made by seeing these masses feeling firm, more circumscribed than the surrounding tissues, not tender, sharply bordered, and easily reducible. And these are other cases. Treatment is by transfixing the palpebral lobe of the lacrimal gland into the upper arcus marginale. And this is, the opening was made through the lateral crease. And here you can see the fat, which is the pre-aponeurotic fat, and the orbital lobe of the lacrimal gland, and this is the bone. This is the technique of transfixing the lobe, the palpebral lobe of the lacrimal gland into the periosteum of the arcus marginale. On dissection, this is the fat taken medially. This is the orbital lobe, and if you do some traction on the gland, you can take the palpebral lobe out. And this is a continuation of the video. The gland is in place, but tossed into the lid. A transfixing stitch is taken through the palpebral lobe to fix it into the periosteum. This raises the gland to the upper direction. And here You take the fat out again out of the way, and you tighten your suture. You notice that the gland comes up. Of course, differentiation between the fat and the gland. The gland looks pinkish white, vascular, and more firm than the fat. So this is the management of lacrimal glandosis. Finally, as I said yesterday, I presented this slide. You open an apple, you discover an orange inside. I presented an eyelid foreign body, cheese wiring of the puncti, canaliculitis, and lacrimal glandosis. The take-home envelope that you probably should take home is never rule out a rarity. Consider common diagnosis first, of course, but think of rare alternatives afterwards. Patient history telling is not always consistent and may miss significant events. And finally, investigations are important and they complement the examination to make the diagnosis. Thank you very much.
Very nice.
Thank you, sir. I am finished now, so I invite Dr. Fairouz, because she missed her presentation yesterday, as I understand. So are you there, Dr. Fairouz?
Hi, Dr. Sharif. Assalamu alaikum.
Hi. Alaikum salam. Please go ahead. Thank you.
So, first and foremost, I take this opportunity to thank Dr. Al-Amri and the entire team, organizing team, for giving me this opportunity here. It's a pleasure and honor to be part of this conference and able to share some of my experience here today. So, I have chosen few case scenarios here, and as Dr. Sharif rightly pointed out right from the beginning and at the end of his slide, that common things are common. So epiphoria is common among oculoplastic surgeons, and Sharif rightly pointed out right from the beginning. And hello, am I audible?
Yeah, you are loud and clear.
Right, yeah. So the most common is dacryocystitis. So let's see what I can, reveal in the next few minutes. I have no financial disclosures or interests, and these are my previous affiliations and current affiliations. So case number 1. This is a 44-year-old lady who has complaints of watering since 2019, and she was referred for a failed endoscopic DCR, which was done elsewhere, to consider DC to me. And she still has persistent watering. So she has also complaints of a swelling, which has been recently noticed 2 months back, which was diagnosed as dacryocystitis. And that was the reason for, the current referral for a failed DCR opinion. So on palpation, this particular mass, which is seen in the medial canthal area near the, lacrimal groove, was firm in consistency. So, what do we do next? In fact, Roplus test is something that was checked. Roplus was negative, and syringing was done, but syringing revealed a bloody tear. So that is quite suspicious. Now, on CT scan and on MRI of this, the orbit, there was a very, very well-defined trifoliate lesion which was sitting in the medial canthal area. And this is how it looked like. And this was the area where, the DCR has been done and the mass is extending. So it's basically a mass which is involving the lacrimal sac here. So what I planned was an anterior orbitotomy with complete in toto excision of the mass because it was well-defined, and then a DCT associated with that. Now, this was how the mass looked like, and this is the, the nasal, the lacrimal, the DCR, initial DCR area where there is a perforation over here, and the rest of it is very well demarcated. So on histopathology, we saw small blue cells, and, the entire panel of immunohistochemistry was done because this looks like a lymphoproliferative lesion. Now, this came out to be a diffuse large B-cell lymphoma, which was presenting as epiphoria and operated for DCR. So 8% of extranodal lymphomas is ocular adnexal lymphoma, and out of which only 3% is diffuse large B-cell lymphoma. It is an aggressive variant. So systemic evaluation was done. The PET scan was within normal limits. The staging was done, AJCC, TNM, and Ann Arbor. She was T3N0M0, and it was stage 1A. And she was planned for systemic chemotherapy, the R-CHOP. I'm not going into the detail of the extensive workup and the treatment that goes for diffuse large B-cell lymphoma, but with a standard treatment, the cure rate is almost 66%, but well, it can relapse in 33%. Next is case number 2, a 48-year-old lady, right eye complaining of watering for the past 4 months. There has been eyelid swelling for 1 month. She complains of nasal block, allergy, recurrent sinusitis. She has septal thinning, which she is on treatment with the ENT, and a very strong family history of, esophageal cancer in the maternal side, the paternal side. And this is what you see here, some kind of puffiness, which is in the periocular area and also in the lacrimal sac area. She had epiphora as well. In fact, a syringing was freely patent. We did CT-DCG, which was within normal limits, and there was a mass, although it's not really visible here, exactly sitting over here, which was confirmed on imaging. She also had a mucosal polyp in the sphenoid sinus, which the ENT decided to observe. So with this presentation, the working diagnosis with a necrotic septum was probably an inflammation of Wegener's granulomatosis, a fungal granuloma, or probably a benign tumor. In fact, I went ahead excising the peri-sac, and the sac was absolutely fine, maintained. The peri-sac lesion was taken out, and again, you can see this small round blue cells over here. Initially, because of the extensive plasma cells which was there, Rosai-Dorfman disease was the initial pathological differentials, but with an extensive panel, they came out to be a natural killer T-cell lymphoma, orbitonasal. In fact, in the next follow-up with the ENT, they also found a polyp where it was biopsied, and it was also proven to be a natural killer T-cell lymphoma. So this is also called a lethal midline granuloma, and it's extremely lethal. And I'm really sad to say that this patient she succumbed to the disease, and she didn't survive for more than 8 months after the diagnosis. Case number 3, a 65-year-old lady, epiphora again, right eye, 6 months, sent for TCR. So the lacrimal sac, well, there was again a swelling in that area, imaging was done, and this came out to be an extramarginal zone B-cell lymphoma where she underwent radiotherapy. Case number 4, another last interesting case. A 54-year-old lady, epiphora left eye, since 1 year, referred for repeat DCR. She's already undergone external DCR twice elsewhere, and it's like a super failed DCR. And she was referred to me for a DCR. Well, there was a mass over there. They thought it was a mucosal. Mucosal is usually a little bit more softer, but this was more firmer mass. A CT scan was done, and this is a large mass, almost less than the size of the eyeball sitting in the lacrimal sac area. And this was taken out, excised in toto, and this came out to be an orbit solitary fibrous tumor with all the extensive panel where, initially there were spindle cells, with vascular typical patternless pattern and vascular pattern in this, and CD3 34 positivity, BCL2 positivity, and CD9 99 positivity with extensive immunohistochemistry workup. So, well, I just want to highlight that epiphora is not always dacryocystitis. There can be certain things very, very rarely hiding behind it. And thank you for your patient listening.
Thank you very much, Dr. Fairouz. A very important bill here. You are ringing a bell which is extremely important on the ocular appearance of B-cell extrazonal lymphoma, which many of the ophthalmologists tend to forget. Thank you very much.
Thanks.
Now, any questions from the audience, the IT people, please? Do we have any questions from the audience? I don't see anything on the chat button here. No, I don't. We don't. Okay. So I have a couple of questions for the presenters, and I'll start with Dr. Mohammed Moin. Sir, I wonder if you ever think of trying beta blockers in the case you present as being, as you were doubting, at the stage of doubt of being a capillary hemangioma. Did you consider this?
Actually, thank you very much, Sharif. Actually, we didn't do the initial treatment for using steroids. That was done somewhere else. And when we saw it at that time, we had definitive diagnosis of AVM, and obviously beta blockers do not have a role because the amount of blood flow that goes through that is much more. But yes,
sure.
Oral beta blockers are the treatment of choice for capillary hemangiomas now, and they should be considered rather than going for the intralesional steroids. Yes, that is true.
Yeah. Okay, right. Thank you very much. Now the second presentation, Dr. Thabit.
Yes.
Thank you very much. Are you implying that the cause of ptosis in your case is purely mechanical due to the inflammatory mass, or is there a sort of a toxic effect on the aponeurosis? As you pointed out, the aponeurosis was thinned out. You said was dehiscent. Is it just mechanical or toxic effect as well?
Well, it could be due to the trauma itself, because there was a trauma, but it could pass through the eyelid and cause the ruptured globe. Or it could be mechanical, as you said, because of the silicone that caused the essence of the levator, or it could be the toxic cause, as you mentioned. Yes, it could be a toxic cause.
Yes, thank you very much. Dr. Muhammad, do we have a couple of minutes more, or are we finished?
No problem. You can have 1 minute at least, to ask a question for everyone very fast.
Yeah, Dr. Sharif, I have a question for Dr. Tariq.
Yes.
Dr. Tariq.
Yes, go ahead.
Yes. Yeah, Dr. Tariq, you showed a patient who had some sort of lymphangioma, and you took out blood from the chocolate cyst or something like that. You took 3 syringes out of blood. What did you inject later? Bleomycin?
Bleomycin, yes.
Bleomycin, and
Yes.
you injected under screen or something like that, or you used ultrasonography while you're injecting, or you just removed the blood and through the same syringe you injected the bleomycin?
Unfortunately, there is no scan or ultrasound in OT. We inject sclerotherapy, bleomycin, in the same site of aspirated syringe. In the same syringe, we remove blood and we put the sclerotherapy in the same site.
Okay, and her vision was okay after this injection?
In patient without exposure keratopathy, the vision returned to 20/20, 6/6. But there is 2 patients with exposure keratopathy under treatment of cornea.
But you are not worried to inject bleomycin, such a very, very powerful drug, without any screening, or because if anything came out and into the orbit, it will make a lot of inflammation and can cause a lot of complications.
Yes, but systemic side effect of intralesional bleomycin is not that large effect. It's rare systemic side effect.
Can I make a comment here, Dr. Sharif?
Yeah, Dr. Fairouz, how are you?
Yes, of course. Please go ahead.
Yeah, just in line of Dr. Tariq. Yeah, bleomycin is the current mode of management in venolymphatic malformation. Now, as you said rightly, it can cause inflammation in the orbit, leading to severe orbital cellulitis, orbital compartment syndrome, but we titrate the dose. So there is a dose which is used. In fact, in our practice, we never go more than 3 ml. 3 ml, when you dilute it, it comes to 3 ml, that is 3 milligram. So there is a kind of a dose titration that we use in these cases. And in a similar line, we actually use a 3-way valve. So it's a 3-way valve. you have one syringe to aspirate, which is attached to one valve, and in the other valve, a syringe is already attached with the bleomycin. So you aspirate, and that's a common needle over there. You aspirate, and after aspiration, you inject your assistant injects inside the space. So there is not.
Thank you very much, Dr.
Yeah.
Thank you.
Okay, thank you.
So we conclude the session. Thank you, everybody. Thank you, Dr.
Thank you,
Mohammed
Dr. Sharif.
Al-Amri. Thank you for sticking to time, for presenting your experience, and hope to see you again. Thank you very much. Thank you.
Thank you.
Bye.
Thank you very much. Bye-bye.